everyone, and very good evening to everyone. I'm Dr. Ajinkya Nanore from Emcure Pharmaceuticals. I welcome everyone to yet another session of the No Thrombosis workshop in acute ischemic stroke. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and wisdom shared by our course director. In the previous workshops, we had a very unique and interesting case discussions, which has helped our online viewers as well as all the doctors who are watching us live. And we are looking forward to have a very fruitful discussion today as well. And it is my honor to introduce our faculty for today. So let me just share my screen. So I first welcome our course director for tonight, Dr. Ichapuria sir. Sir is director at neurology at Sahyadri Hospital, Pune. Sir has the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. Sir has more than 300 public lectures and workshops on stroke, and he has been a member of Indian Stroke Association. Sir has been a organizing president of StrokeCon 2012 and ISS Stroke School. He is a founder of Pune Stroke Group and ex-president of Society of Neurosciences Pune and Maharashtra Academy of Neurology. Sir has been principal investigator for many multinational stroke trials like Perform, BrainsGate, BG12, etc. And he has been recently awarded as the health icon by the Times of India Group. Welcome, sir. Welcome to this workshop.
Thank you. Thank you so much.
Then I welcome our first moderator for tonight, Dr. P.C. Gilwat sir. Sir is professor and head of the Department of Neurology at Jubilee Mission Medical College, Thrissur. Sir has started the first Department of Neurology in Thrissur in 1988, and it was the probably he was the probably first time neurologist in that area. He is a member of International Forum of Teachers in Bioethics, UNESCO, American Academy of Neurology, European Epilepsy Academy, Movement Disorders Society, the Neurocritical Care Society, Indian Academy of Neurology, Neurological Society of India, and the Indian Stroke Association. Sir was also a member of Board of Studies for Kerala University of Health Sciences and the chairman for Super Speciality Board. He has been a national faculty for training in bioethics, and he has been a past president of the Thrissur Neurological Society, the Kerala chapter of the NSI, and the Kerala Association of Neurologists. Sir has been an invited speaker at several national as well as international meetings, and he has multiple publications in various journals. Welcome, sir.
Thank you so much.
Then I welcome our second moderator for tonight's session, Dr. Dinesh Chauksi sir. Sir is consultant neurologist at Kokilaben Dhirubhai Ambani Hospital, Indore. He has a special interest in stroke, Parkinson's disease, and movement disorders. Sir has more than 32 publications in various national and international journals, and also won a first prize in e-poster presentation in epilepsy section in Indian Academy of Neurology National Conference in 2014. The special skills and interests are neurological emergencies, management of stroke, and special interest in Parkinson's disease and movement disorders management. Sir has expertise in video EEG, NCV, and EMG, autonomic function testing, and tremor analysis. Botulinum toxin therapy in movement disorders and spasticity, and he has also trained in deep brain stimulation in patient selection, planning, and programming ECMT in April 2022 from Kochi, India. Welcome, sir. Welcome to this workshop.
Thank you, Ajinkya.
Yeah. Then I welcome our first expert speaker for tonight, Dr. R. Ramma ma'am. Ma'am is a consultant neurologist at Tirupur Medical Foundation Hospital and Aadhar Multispeciality Medical Center, Tirupur. She has more than 6 poster and paper presentations at various conferences and also participated in debate IVIG versus rituximab for myasthenic crisis at TANCON 2021 in Chennai. She has been an author for current concepts in gut neurology, reviews in neurology, IONCON, Agra. Welcome, ma'am. Welcome for this session.
Thank you.
Then I welcome our second expert speaker for tonight's workshop is Dr. Siddharth Singh. Sir is consultant neurologist at Sahyadri Super Specialty Hospital, Eravda, Pune. Sir has done fellowship in stroke and also has a Melvin Yar Young Scholar Travel Grant. Sir has done multiple platform presentations in various national conferences, and he has also been a runner-up in a national stroke quiz. Welcome, sir. Then I would like to hand over this session to our course director for tonight, Dr. Ichaporia sir, for the context setting and his opening comments. Sir, over to you.
Yeah, thank you for the introductions and the kind words. And I think this is the 15th or 16th no thrombosis Zoom meeting, and I think it's been a great success. And I think average of 250 to 300 the participants have been there. And I think last time we had
almost 400.
375.
Yes.
So this has been all over India, and we are very happy. And we've learned so many things, and so many young people have presented their cases, and they've been so exciting, and everyone has taken a lot of interest. And I am very, very happy that Dr. Gilwas has joined us today. Besides all his good credentials, I think the most important thing about him is the wisdom that he gives to young people. I've heard him a number of times, and every time I've been very much impressed by the wisdom. It's not knowledge, it's the wisdom. There's a difference. So, Dr. Gilwas, we are very happy to have you. And I'm sure you will impart more wisdom to all of us today after seeing the cases. And Dr. Dinesh Choksi, welcome. I think this is the first time you are in this panel as a moderator. And I'm sure that you will contribute a lot and also learn. So, it's not only contribute, it's also, all of us are learning, and we have to, this forum is for lifelong learning. And I think that is the most important thing. And I'm sure it will be a very, very good program. And I now request Dr. Ramya to present her case. Dr. Gilwas, Dr. Choksi, would you like to say something before we start?
Let's start.
Yes, let's start.
Ma'am, you can start sharing your screen.
Okay, I'm sharing it.
Yeah.
Very good evening to one and all. Thank you for giving me the opportunity to present in this forum. I think I'm presenting for the third time in the same forum. To say about myself, I'm a consultant neurologist at Tirupur, going to two hospitals, and other medical center. IV thrombolysis here. For thrombectomy, we usually refer to higher center. So going into the case, the sudden onset of weakness with deviation of angle of mouth to the right since 2 hours. On 4th of February, she was doing well till the previous day. She had a slurring of speech alone. On that day morning, she was taken to a nearby hospital. She was given some IV fluids, and she says she recovered completely. She is on diabetic and hypertensive medications, but with a poor control. On examination, she was afebrile, and hydration was good at the time of examination. She was not pale, no cyanosis, no clubbing icterus. JVP was not raised. Pulse rate was 110. BP on the right upper limb was 180 by 100, and on the left 190 by 100. Her sugars were 324. Her cardiovascular, respiratory, and abdomen were normal. Coming to the CNS examination, she was conscious, oriented, dysarthric, gaze. On the right eye, there was no extraocular movement. On the left eye, only abduction was possible with nystagmus. like 1.5 eye syndrome like presentation. She had a left human type of facial palsy and complete hemiplegia on the left side with a power of 0/5. NIHSS at admission was 11. She was admitted in ICU. I couldn't take on the day of the examination. This is a little after thrombolysis.
வயசு 57 58 கண்ணை இறுக்கி மூடுங்க. ஈன்னு சொல்லுங்க. பள்ளி ஈ சொல்லுங்க. கண்ணை தருங்க. கை விரல் காமிக்கிறேன். தலை திருப்பாம இந்த விரலை மட்டும் பாருங்க. விரல் எங்க போதோ அதை பக்கத்து பார்க்கணும். நேரா பாருங்கம்மா. விரல பாருங்கம்மா. விரல பாருங்க. இந்த பக்கம் பாருங்க.
So that was the eye finding. MRI stroke protocol was done. She had a right hemipontine infarct with no major vessel occlusion. Her blood investigations were grossly normal. HbA1c was 13.8 and ECG no significant STT changes. This was the MRI. Sorry. This shows the diffusion restriction in the pons and there was no major vessel occlusion. Basilar artery was seen clearly. The same thing with the report showing acute infarct in the right hemipons. So she was thrombolyzed with injection tenecteplase 0.25 milligram per kg at 3 hours and 40 minutes window. She was also started on insulin, antihypertensives and other support measures. Follow-up CT brain was 21st. There was no bleed. On day 1 after the lysis, mild improvement in the facial palsy was noted, but the eye findings and the powers were the same. Vitals were stable, so she was shifted to ward. She was started on oral beats and physio. By 7th day, her eye movements became better and the limb power improved to 3/5. She became ambulant with support, but she had gross ataxia. She was discharged and advised to review after 2 weeks. During the first review, after 3 weeks of lysis, the gait completely improved, but the EOM not recovered. During the last review on 15/5, that is 68 days after the thrombolysis, she completely recovered. This was the eye finding on day 7. That is on the day of discharge. I didn't take the video on the review on 68th day, so I told the attendant to take the video 2 days ago at her home. This was the present status.
கண்ணு திறப்பு. அந்த பக்கம். இந்த பக்கம். கண்ணு உருட்டிக்காம. நல்லா இருக்கிறேன் இப்ப ஊசி போட்டதுக்கு அப்புறம்.
She's telling she could talk well and she could do her cooking activities by herself. So just the point of interest is her eye findings, which recovered, though with not on the day of discharge. Within 3 months, the deficits were all recovered. Just recap about the blood supply. Pons receives blood supply from three groups: anteromedial, lateral, and dorsal. Anteromedial group is from the terminal branches of vertebral and basilar artery, which supply the paramedian ventral pons, including the corticospinal tract, bilateral MLF, medial lemniscus, and abducens nucleus. Lateral group is from the anterior inferior artery, superior cerebellar artery, and long artery. Dorsal group from the terminal branches of skull. So there are many named syndromes. In general, to make it easy, it is lateral pontine, medial pontine, and ventral pontine syndrome. Lateral pontine has ipsilateral spinocerebellar, that is ataxia, Horner syndrome, and facial numbness, and contralateral loss of pain and temperature, along with seventh nerve palsy. On medial, that is medial pontine syndrome, presents with contralateral hemiplegia due to corticospinal involvement, and loss of contralateral loss of vibration and proprioception, INO type of picture, and gaze palsy, loss of function of gaze palsy. So ventral pontine is also locked-in syndrome. Patient has the complete quadriplegia. The possible movements are only the eye movements, eye blinking and EOM. These are the name syndromes. Just for recap, I put in. So our patient had both medial, most of medial pontine presentation, also had ataxia on the ipsilateral side. So we thought she had both medial and lateral pontine features. The point of interest for her presentation is the 1.5 eye-like syndrome. Right hemipontine infarct of this patient has caused lesions of the right PPRF and MLF, resulting in the right lateral gaze. That is, right eye abduction and left eye adduction is lost, and ipsilateral INO, paralysis of right adduction, and nystagmus of the left eye on abduction. The most common cause of the syndrome is vascular, followed by demyelination. The same thing in picture. So I had a short second case also. If you permit, I'll just go through. Can I, sir?
Yes, carry on.
Yeah.
This is another patient, 87-year-old female. She is known hypertensive on irregular medication, presented with sudden onset left-sided weakness and difficulty in speaking since 1 hour. On examination, she was conscious-oriented, dysarthric, and left hemiplegia, 1/5 power with the NIHS 11 at admission. BP was high. She had a right MC-tertiary infarct with no major vessel occlusion. BP was brought down with the antihypertensives. This was her MRI showing infarct in the right parietal and a little bit in the corona radiata region. And major vessels were all normal. So attendants were explained about the pros and cons of IV lysis, got consent, and she was thrombolized with tenecteplase at 2 hours and 14 minutes of window. The follow-up CT next day revealed no bleed. The power improved to 3/5 on day 1, and she was able to stand with walker on day 2, and she became ambulant by day 4 without support. Later, we noticed she had a severe ecchymosis as she fell down at the onset of stroke in the steps. So she had left-sided full ecchymosis. She had pain, and it was managed with analgesic. She was discharged on day 5 without any deficits. This is at the time of discharge. She's 87. She fell down over the steps, so she had this confusions over the face, neck, and arms.
அப்படி பின்னாடி நடங்க, இப்படி திரும்பி
This very simple case, but why I presented was her age. She was 87. I had little difficulty in convincing the attenders for the IV thrombolysis. She was the eldest person thrombolized in our center, but she recovered very fast and there was no complication. The second eldest person was 85 years male who also recovered without any complications. So as per the SMART criteria, for thrombolysis, age is not the limitation. I thought I will share this case also. Thank you, sir. That's all is my presentation.
Thank you, Dr. Ramya.
So thank you, sir.
uh, Dr. Gilvaz, can you comment on both these cases?
Hello. Yeah. No, I think you've been very lucky in both the cases. The first case just, I think, highlights the fact that long after we have thrombolized, as we know, reperfusion is now at the very core of any stroke therapy. And we feel that just because the half-life of the drug is just a few minutes, that's when it begins and ends. No, it keeps acting, which is the cause why we have bleeds much afterwards. We have bleeds 24 hours, 48 hours sometimes. So therefore, the drug acts a long time after we think it has stopped acting. And I think this is exactly what has happened in your case. And of course, there is the phenomenon of natural recovery as well. This was your first case. The second case, yes, I fully endorse your view that age should not be a criteria. She was 87, but I think even we too have begun to liberalize and if we find a healthy, active 87, not a bedridden 87, with no comorbidities, we also would go ahead and thrombolize.
Thank you, sir.
Dr. Choksi?
Yeah. Sir, I want to say that it's always be, lucky if you do not have, say, next day bleed in your CT scan. There is always a fear because of that. This risk we have to be in each and every case, though we know that natural recovery is there for the period of time of, say, 3 months or 90 days. But still, we have to give a better recovery chance to a patient with all these things and say debate related to that small lacunar infarct to be thrombolized or not. So give this benefit to the patient. And I think both of the cases Dr. Ramya has taken and thrombolized. I'm fully agree with that. And fortunately, the patient recovered very well. I'm also thinking in that way that not that immediate say benefit in some patients we will observe, and after say few days, if compared thrombolized versus non-thrombolized patients, there must be a good recovery in thrombolized patient as compared to non-thrombolized patient, as per my experience what I'm having. Sir will comment better on it. Chavriya sir.
Yeah, I agree with all that has been said. And Dr. Ramya, congratulations to you. At one time we used to say age above 80 we shouldn't give, but that's all in the past. All these criteria have been liberalized. Why these so many contraindications were there? Because they wanted the study in the 1990s. They wanted the studies to be positive. So they took only the best cases, because all previous trials had failed with thrombolysis. So they had to show that some drug is working in thrombolysis, and therefore they put in so many contraindications, and everyone, used to mug up those contraindications and talk about them. But as time has gone by, 25 years have gone by, 27 years have gone by after that first paper, we have become more liberal, and there is no upper limit for age. People have thrombolized 90-year-old and 95 years old. They don't do so well because of advanced age. But in your case, of course, that lady has done very well. She must have been very good. And of course, as Dr. Gilvaz said, if the person is in bad shape, if there is dementia and there are many other comorbidities, of course, we would not thrombolize such a patient. But if the person is mobile and active and mentally okay, there is absolutely no contraindication. And, this thing of lacunar strokes, there was a lot of debate, okay, lacunar stroke, should you thrombolize or not? But it has been found that all lacunar strokes also do better with thrombolysis. It is not a contraindication. People used to say, it's a contraindication. Why do you want? Lacunar is because of, the lipohyalurolysis, and, that will not produce benefit with thrombolysis. But time and again, it has been shown that lacunar strokes also do better, and they are quite disabling at times. Just because it's small, but because it's very strategically located, it is highly disabling.
Yeah.
So, and both your cases have had NHSS more than 10, 11, 12, 13. So it was a disabling stroke. So there is no point in not giving. Not giving thrombolysis, I think, is gone. If you don't give thrombolysis, I think you are at risk for getting sued in the court.
Yes.
Why did you not give thrombolysis? Everything is fitting. Everything is fitting. There are no major contraindications. So if you don't give thrombolysis, you will be in bigger trouble than if you give. So, as I always say, that you must find a reason to give and not an excuse not to give. People find lots of excuses. I saw something like this and something like that. These are all excuses. And I don't think we should worry too much about bleeding. Of course, it occurs, when you've given many patients. Of course, some people will get bleeding. Yeah. But even then, if you see statistically, you have done good for the patient with thrombolysis. So they recover. Many people say that anyway, that lacune would have recovered in 3 months. Why did you give? But more patients will recover with thrombolysis than if you had not given. Of course, some will recover spontaneously. We have seen that umpteen times, that they do recover spontaneously. But many more will recover with thrombolysis if given properly than if you have not given. So it is definitely an advantage, and it is across the spectrum. It is for minor strokes, not very minor strokes, but minor strokes, or what we call disabling strokes, moderate strokes, large vessel strokes, small vessel strokes, medium vessel strokes. Across the board, it is severe strokes also. Across the board, there is benefit of IV thrombolysis. Of course, in very large vessel strokes, we would go the additional step and do mechanical thrombectomy. But still, now many centers all over the world, not only in India, they cannot do mechanical thrombectomy. So that doesn't mean that because you cannot do mechanical thrombectomy, you will not give thrombolysis. I think that's most stupid thing to do. Okay, if it is a really large vessel stroke like internal carotid or basilar or M1 segment, then you transfer. If you don't have the facility, everyone can't have the facilities. It's not possible. Nowhere in the world it is possible. Forget about India. India is a developing country still. We have our problems with money, transport, availability, accessibility, so many issues. So, but don't deny people such a good treatment.
Yes.
And you have shown very beautifully that, basilar stroke, which was occurring in hemipons, that also recovered. Normally, we don't see this 1.5 recovering, or even this internuclear ophthalmoplegia. It takes a long time. So all the studies have shown, have done the MRS at 3 months. So you have shown your patient at 68 days and that she had recovered, and her MRS had come to almost say 0 or 1. I don't know if she had any symptoms. Maybe she had a little hemisensory symptoms, maybe. So MRS 1. Second patient, I think, was MRS 0. So such type of patients will really bless you a lot, Dr. Ramya, and their family will love you a lot for being active, aggressive, and helping patients. So I think it's a very, very satisfying feeling. At least for me, it is a very satisfying feeling. Dr. Gilbas, what would you like to say?
Just one thing.
Yeah.
Dr. Ramya, what would you have done if one of these patients had bled? It's an awful thing to come the next day and see a bleed, but what would you have done?
So if the bleed size is small, we will manage here only, sir. I have presented in my second case a very large bleed actually post thrombolysis. Young person with secondary hypertension who bled huge, but they didn't want to go to higher center due to lack of money. They said like even if the patient dies, it's okay. You treat with medical management. We treated and patient was with us for 21 days and he recovered completely.
No. What is your protocol of treatment when they bleed? Like, what do you do first? What do you do next?
So I'll be strict on my BP. Depending on the size, if the patient needs, maybe mannitol I will give. And BP control is my main target. It will be so. Well, after 1 or 2 days, I will definitely start on antiplatelets and statins. Statins immediately I'll start. Antiplatelets I will start 1 day later.
No, since we asked,
if there is a bleed, why will you start antiplatelet so fast?
There's no possible.
Maybe later.
Later,
Not
yeah.
Yeah.
I will wait.
No, but suppose, so would you classify the bleed as, hemorrhagic infarct, or parenchymal hemorrhage, or how would you handle such a patient? I mean, in your career, you will have to handle this.
Exactly.
This type of thing will happen. If you're doing hundreds of thrombolysis, it's going to happen. So you have to be prepared. So
Yes,
first you have to be mentally prepared. So
Yes.
how will you be mentally prepared?
So if it is non-occlusive site bleed, it is bleed. If it is in the same site where I got the infarct, it could be a hemorrhagic transformation. Then my strategy will be to be strict on the BP control. If necessary, mannitol or anti-edema measures.
no, really, we go by a few things. Even
Yes.
this hemorrhagic transformation, is it just some few, hyperintensities in the periphery when you call it grade 1? Or is it scattered diffusely throughout, when you call it grade 2? Or is it an intraparenchymal hematoma? Right? Now, these are quite different situations. Now, if it were a hematoma, you wouldn't like to sort of start your antiplatelet into I would wait a good
Yes,
deal
sir, I
until
will wait.
I
If it
see
is
resolution a
I
lot.
will definitely wait if it is a
Number 2 is I would immediately, not only the BP, I would also use cryoprecipitate, about 10 units of them. Most of your blood bank will have it. Don't worry. There's plenty of cryo. I think you should give straight away some cryo, some tranexamic acid. For whatever it's worth, we do give it. And of course, BP control is so important. But something more than just watchful expectancy, because these things will tend to become bad over time. Because once a bleed happens, edema will set. Edema setting in is a different ballgame. So it's just to bring back the fact that you were lucky, God bless you. But when things go wrong,
Yes, sir.
what is the right thing to do?
Okay. Thank you, sir.
Yeah, so this Dinesh, yeah. Continue.
Sir, I want to say that this will happen. So you have to be very well explained to the relatives about it, the percentage, possibility of the bleed, and if unfortunately we have this situation, so manage accordingly, and it is very well explained to them. So I don't think so there must be a problem, but it has to be faced, and definitely with having this much of fear. So giving excuses and not to thrombolize is also not a good thing. One more thing I want to say, that this is a point fact that lateral medullary syndrome, in fact, it is also one of the very strategic infarct. And if it is really very bothering or cumbersome and difficult and morbid for a patient with lateral medullary infarct, because he's not able to swallow and there are a lot of secretions. So these people can get benefit, come on time with thrombolysis, I think. Yes, sir.
Yeah. Anything more you want to say, Dr. Ramya? Did you control the blood pressure? Your blood pressure readings were little on the higher side.
Yes, sir. I will bring it down to the target and then only we will.
How much was in your second patient? It was what, 190, you said, systolic.
Yes,
no?
So generally we bring it below 160/90. It's not as per the protocol, but still I keep it my target less than 160/90. That's why there is a delay. Though patient comes with an MRI to me, The door to needle time was more than 1 hour in both the patients because of the time taken to control the BP. And since it is a periphery, I'll be very strict on BP. I will bring it down to 160/90. I don't mind if the time is going little 15-20 minutes. It takes also. I'll wait. I'll bring down the BP and then only I'll thrombolyze. I'll stay there for some more time to see the BP stables after lysis also.
Why are you doing MRI and not CT scan?
So this is a referral center. Some patient they come with MRI. In our center, we have only CT. We do CT cerebral angio, and then we lyse.
Yeah, so both these patients came with an MRI.
Yeah.
They wasted 1 hour.
Yes.
So this is the problem. They're coming, they're
That's why
going
if
to
you
a
see,
small
they come
hospital.
with they come with the window period of 2 hours, 40 minutes. They would have gone to a clinic. From there, they would have been referred to a MRI. They will come with MRI. Even
No,
the patient comes with
we
MRI.
have to, I think, we have to educate our referring doctors and this thing that they should come directly to you.
Yes.
And, this wasting time of going to MRI, doing the MRI, that will take easily half an hour, 45 minutes in the best of situations.
Yes.
In the best of, traveling across putting in patient in the ambulance, going to an MRI center, coming back, and then coming to you have wasted already 1 hour. So somehow we have to insist, and this is what public education is, not only to public, but also to referring doctors. These referring doctors, I don't know what it is in your place, but in our place, these doctors are most unwilling to let the patient go. And they're doing this MRI and sending the patient after 3 hours and 4 hours. So then and some of them give heparin and Clexane and something like that. And so then, we are in trouble. So I think the public education for doctors, even neurologists are doing this, unfortunately. Sorry to say. And of course, the public, that directly when the patient comes to a stroke center, whether it's primary stroke center or secondary stroke center, CT scan is good enough. CT scan, CT angio is good enough for most patients. Okay, when it's posterior fossa, when it is outside the time window of 3-4 hours, then yes, there are special situations where would you prefer an MRI, no doubt about that. But run-of-the-mill early patients, I think we can, bypass this, and you will find that your results are much better. And your risk of hemorrhage is lesser, your recoveries are better, patients are happier, and of course you waste less time. So perhaps you could think of that. And yes, what you did for controlling the blood pressure is very important. Even the first patient had high blood sugar. So is that a contraindication? High blood sugar?
No. So nowadays, the only contraindication is intracerebral bleed.
Yes, very good that you said that. Yeah, okay. So all the contraindications, as we said, have been whittled down to, very, very basic things like bleeding somewhere, either in the brain or in the gut, or recent surgery, or, platelet count is very low, or something like that. Whether he has bled or he's likely to bleed, this is the only contraindication. And of course, if the BP is very high and you can't bring it down quickly, these are the main real contraindications. But otherwise, hardly any contraindications now. Few, of course, you have to be careful. Of course, there's no doubt that you have to be careful. You can't be a Rambo and do everything. But do more rather than, find excuse not to do. That is at least my message.
So what your opinion regarding that chronic liver disease and possibility of varices, and second thing, that infective endocarditis possibility?
See, if there's a history of fever and infective endocarditis, is a contraindication for IVT. No doubt about that. Chronic liver disease, not a contraindication. Chronic renal disease on dialysis, not a contraindication. Unless the platelet count is low. Just because you have thrombolized the patient, the varice is not going to bleed. unless there is active bleeding of the varices, or there's an ulcer in the gut which is actively bleeding. I mean, it's okay. You can still give. So even dialysis patients you can give, and at least Actylase, so definitely you can give. Tenecteplase, I'm not so sure, but Actylase definitely not a contraindication. So but in liver disease and all, we would be a little scared because we would like to see the platelet count. So that will waste another half an hour, and we don't like this. And you would like to do the PT-INR also. So you would like to do, so as I said, likely to bleed or has bled. These are the two complications. I mean, these are the two contraindications.
Yes. And
So
one more thing
liver disease, if you think platelets are low or INR is high, of course you cannot give. So because he's likely to, but if it's a stable liver disease, and INR is okay, the platelets are okay, then I don't see any reason not to give. Yeah. Okay. I think we've discussed it very well. Thank you, Dr. Ramya.
Thank you very much, sir. Your words were very encouraging. I will go ahead in
What?
doing the thrombolysis.
I didn't hear. Sorry.
Your words are very encouraging to me. I will go ahead with more thrombolysis.
No, that's the idea. We want more people to do it because, it gives so much benefit. And finally, even if you do a cost-benefit analysis, it is the most effective treatment for stroke. Even if you improve the NIHSS or MRS by one grade, you have done patient a lot of good because he's become independent. Otherwise some family member will have to take him to the bathroom, will have to bathe him, will have to dress him, so the whole family gets disturbed. And somebody's made a calculation that each stroke cost of untreated stroke costs a family, if he survives, 5 lakh rupees in the first year. So, they've done a cost, and somebody sat down and done a cost analysis. So if you give thrombolysis costing, say 50,000 or 60,000, including hospitalization, or up to 1 lakh, still it is beneficial, even if you have improved the patient by a few grades or 1 or 2 grades also. So if he has improved completely, of course, there's a great benefit. But even if he's not improved completely, if he's become independent or semi-independent, you have done good for the family. Okay. So thank you, Dr. Ramya. Very encouraging that. What is the population of your city?
It's a big place. It's a big place.
Approximately about 10 lakhs?
Maybe.
What we are finding, that people in smaller places are doing more thrombolysis than people in big cities because they can come faster. In these big cities, they get stuck in the traffic and they don't come to the hospital fast. So we are encouraging people to do in smaller places because they can do it well. What do you need? You need a CT scan, and you need intelligence, and you need guts. That's all you need. So, you can do so many good things for people. Thank you.
Thank you.
Thank you.
Yes, Dr. Siddharth, could you?
Yes, I'll start sharing my screen, sir. 1 second.
I just want to give one comment that for a neurologist, it will be difficult to answer the population of the city rather answering the questions of the acute stroke thrombolysis. It's a matter of GK.
So Ramya is going to go back after this meeting and find out the population of our city.
We are very well in neurology, but struggling when the GK comes in picture.
Abhi GK kya hai yaar?
And day-to-day activities also. We are lacking in the daily news also.
Yeah. Okay, come. Let's start the next one.
Hello, good evening, everyone. So I'm Dr. Siddharth Singh. I'm working as a consultant neurologist. I finished my fellowship in stroke under the guidance of Dr. Nasli, sir. and I'm working under him as a consultant neurologist in Sayadri Hospital, Nagar Road, Pune. So I'm going to discuss cases with the common theme of thrombolysis in large vessel occlusions. So this is our team. This is in our newly developed neuro ICU, which we have started from the 1st of June. So as you can see, me and Sir are in the center, and we are flanked by Dr. Kajanan and Dr. Sanjay. We are the 4 core members of the neurology unit here, and we are always present, always ready to do whatever is necessary in a patient with stroke. But we cannot do it alone. So this is our extended team, including the interventional neurologist, Dr. Lomesh, interventional radiologist, Dr. Corby, and our ICU team. The radiologists are not on this picture, but they're also a core part of the core stroke protocol. So starting from our first patient, 60-year-old lady, she had past history of stroke in 2016 when she had a left hemiparesis which completely recovered. She was told at that time that she has a cardiac ailment, and for that she was put on single antiplatelet beta blocker digoxin, but not on any anticoagulation. Following that, she had presented to us with acute onset right hemiplegia and left gaze preference and aphasia since 7:30 p.m. and she reached the hospital at 8:20 p.m. So that was around 50 minutes from onset. Her pulse rate was bradycardia with 50 pulse per minute with atrial fibrillation, and BP was 150/90 and sugar was normal. Her NIHS was 18 at presentation. So as per protocol, we immediately took her to CT scan. The CT, as you can see, the aspects was good. There was no evident infarct seen, but in the angiogram, we saw large vessel occlusion, which was expected with the large NIHS. So you can see the left MCA proximal occlusion is there, which was confirmed by our rapid AI software. So this patient didn't actually need a perfusion, but by the protocol, it takes only 25 more seconds. So we do the perfusion also for our patients. So the large vessel occlusion was detected, and hence we immediately went for thrombolysis. And the patient was thrombolized with tenecteplase of 17 milligram according to weight, and door to needle time was only 15 minutes in this patient. Our time of stroke onset to needle time was 65 minutes. By the time she was shifted back to casualty, she was already started showing dramatic improvement. First, the head and eyes deviation, that is the gaze palsy, recovered. And then after 5 minutes, we found that the limb power was also improving. And finally, aphasia, she was completely aphasic when she came, but then she was able to speak, but there was some residual dysarthria. So NIHS had dropped from 18 to 2 in within 10 to 15 minutes of thrombolysis. So because we wanted to see how the vessel is looking, we went for a non-invasive method, that is MRI, to look at the vessel. The MRI diffusion did not show any infarct yet, but the occlusion which was there in the proximal of left M1 had now gone to the M2 segment. As you can see in this image, the superior division of MCA is well seen, whereas the lower inferior division is not well visualized. So probably the thrombus had migrated to that part. So we wanted to do a DSA angiogram to see how is the flow across that, or if do we need to do a thrombectomy, because the patient had a still tissue at risk and we didn't want to leave the patient with further deficits or with further worsening. So we went for the angiogram. So here you can see that, as in seen in the MRI, the superior division is showing very good flow, but the inferior division is a very thin flow or a slowed flow, and it was feeling slower than the superior division, but there was flow across the inferior division also. So considering the difficult nature and the very small deficits, we did not go ahead with thrombectomy. We felt that the thrombolysis was working well enough and this patient was expected to improve. So the patient, after shifting from the cath lab to ICU, at that point her NIHS was 2 with speech and gait disturbance, and over the course of hospitalization that also improved with only mild dysarthria being the residual deficit. So her 2D echo revealed rheumatic valvular disease with the mitral valve showing moderate mitral stenosis. 1.3 centimeters square was the orifice and LA size was dilated. So she was started on warfarin considering cardioembolic stroke with rheumatic valvular disease. So this patient completely improved despite having a large vessel occlusion by thrombolysis. Then the second patient, who was a 60-year-old male, he was a hypertensive. He presented with acute onset right-sided weakness, which was grade 2/5, speech disturbance and facial palsy on the right side since 3 p.m. He reached the hospital after 2 hours, 20 minutes, and at presentation, NIHS was 14. Pulse rates was 78 per minute, BP was 168 by 80, and RBS was 125. So he was also immediately taken for the scan. Here you can appreciate mild subtle hypodensity in the subcortical region, which was found to be of aspect 7 as per the rapid AI protocol. However, that
just show where.
Yes, sir. Here you can see that this area is
with the pointer.
Yes, the pointer. Can you see the arrow, sir, in this? Or?
No.
No.
Bring your computer thing, no? Bring your computer pointer.
I've shown it, sir, but it's not being
okay, continue.
So in the second image, as you can see, the red areas which are on the left side of the CT scan in the second image, which are red, those are the areas which were hypodense. So this is how it is picked up in the rapid AI, whereas the blocks which are not showing red, they are transparent. Those were the non-affected areas. So there are 3 areas out of 10 which were red. So aspect score was 7. So a good aspect. However, the angiogram we can see was showing again left M1 segment thrombosis, but there was some flow beyond distally. We can see a thin rim going across, and then the distal flow and collaterals were good. So this patient had at this present only infarcts or core in the lenticulostriate area, whereas the distal perfusion was still good through collaterals and some flow through the clot. So here you can see we have measured the clot distance, clot length. So it was around 1.29 centimeter or 12.9 millimeters. So this is the length of the clot which was seen in the angiogram. So as you can see in the perfusion, the red area, which is in the final image, the blue area is the good perfusion and the red is the area which is underperfused or at risk. That's the penumbra. So as we can see, the core was only the lenticulostriate, whereas the penumbra was quite big, and the area tissue at risk was almost the whole of MCA territory. So this patient had to go for recanalization either through thrombolysis or through thrombectomy or both. So we have immediately thrombolized the patient. In the second image, you can see that the collaterals on the left side and right side are almost similar. So the flow distally was good. So this patient, even though he came after 2 hours, 20 minutes, he was still having a good chance if we opened up the vessel. So he was thrombolized with tenecteplase 18 mg. Door to needle time was 22 minutes. Onset to needle time was 162 minutes because he arrived after 2 hours to us. And IHS improved from 14 to 5 immediately. So considering this like the similar situation like last time, we took for a non-invasive method to look at the vessel non-invasively. So here we saw that there were already some watershed infarcts in the corona radiator region. The dot infarcts were seen and the occlusion was still there in the MR angio. So considering the big tissue at risk, penumbra was big, patient was taken to cath lab. However, when we reach the cath lab, as you can see in both the images, MCA is showing good flow, very beautiful flow is seen in the distal region as well. So the MCA was showing complete recanalization. So by the time the patient was shifted from MRI casualty to cath lab, the tenecteplase had opened up the vessel fully. So this patient also didn't need thrombectomy. And as soon as the patient was taken out of the DSA procedure, we saw that his limb weakness had improved even further to 5/5 and only mild dysarthria was there. So NHS had come from 14 to 5 and now to 1. And he was continued with the care, dual antiplatelets and statin, and he was discharged with MRS of 0, no deficits on the 4th day of admission. Now, finally, the third patient. She was a 68-year-old lady, hypertensive. She had acute symptoms since 11 a.m. and right-sided gaze preference, left-sided dense hemiplegia and dysarthria. She also came in around an hour to us, and NIHS at presentation was 15, with pulse rate BP being 150/88, pulse rate being 90, and sugar was also normal. So we have gone for the MRI, for the CT scan. CT scan was completely normal, aspects was 10, but as you can see on the right, proximal M1 occlusion is there. The flow is not there in the middle proximal part, and beyond you can see that there is some flow across this thing. And in the second image, you can see that the collaterals on both sides are equally seen. So the collateral superficial flow was good. So this patient was similar to our last patient, and if we open up the vessel, she had a good chance of recovery. So we have measured the clot. As you can see, it's a long clot, 0.29, that means 29 millimeter. So it's quite a long clot. And as you can see in the perfusion imaging, that the area which is blue and red in the different images, that's a big penumbra with a small core. That means the core was almost not yet developed, whereas the tissue at risk was quite big. So using all this information, we thrombolized the patient. And she was thrombolized with tenecteplase 16 milligram, and door to needle time was again quick, 20 minutes. Onset to needle time was 88 minutes. And NIHS had improved to 10 minutes within to 0 within 10 minutes of thrombolysis. And in view of this very early neurological improvement, which is known as VENI, again we have chosen the non-invasive method. This was actually between the CT and MRI. You can see her working. So other than a bit tentativeness due to the square and new place, she was actually had no deficits. And this was within 5 minutes actually of thrombolysis. So as we can see in the post thrombolysis scan, right MC occlusion has opened up completely. So she has again, she was not even taken to cath lab because she had no deficits and the vessel was showing. She was kept in the ICU with a close watch, and she did not show any further signs of worsening. So she was discharged on day 3 on dual antiplatelet and statin, and MRS was again 0 at discharge. So how do we determine which large vessel occlusions, which middle MEVO occlusions can open up? So we have to look at the location of clot. Obviously, the more distal the clot, the more the chances of opening up. But as demonstrated in our 3 cases, even proximal large vessel occlusions can open up with just thrombolysis. Then clot length, that we will discuss, and thrombus permeability are also 2 things which we will discuss. Then relative and absolute attenuation values. This is nothing but the Hounsfield unit. So what you can do is you can take your cursor from the CT scan and place it on top of the thrombus. It will show a Hounsfield unit value. So they say that the higher Hounsfield unit, that denser the clot and less likely it is to open up. And then there is something known as clot burden score, which we will describe with the image. So what are these red thrombus versus white thrombus? So atherosclerosis is known as the red thrombus because it has higher quantity of RBC and it shows increased attenuation. That means the Hounsfield density is more due to increased RBCs. It is a more dense clot. It usually leads to this hyperdense MCA sign also. And it can be associated with calcification in and around the lesion as well because of atherosclerosis. Whereas cardioembolic will have increased perviousness. It will have more fibrin and platelets, hence it's called the white thrombus. This pathological article has shown how many different types of clots are there. But for our usage, we will see basically white clot and red clot and divide it into it. But even this pathological specimens show that there are so many different types of clots with different proportions of platelets, fibrin, and RBCs. But for practical purposes, we will define it into white and red thrombus. So this is the clot burden score. Here you can see that whatever is not visualized in the angiogram, we have to give it a number or marking based on the clot burden score. So in our first patient, you can see that beyond M1, nothing is visualized. So we have to start giving the numbers or the scoring from proximal M1 MCA, then distal M1 MCA, and then M2 branches of superior and inferior division. So her score will come out to be 6. Whereas the other 2 patients had proximal M1 not visualized, but distal flow was there. So their scores are only 2. So the higher the clot burden score, the less likelier it is to open up. So we have to use this as a angiographic measure to say what is the clot burden. How obviously when you open up the vessel or do the DSA, then obviously you are having a more accurate length calculation. But in this patient who is just on the CT angiogram, also we can approximate the clot burden. Then this is the permeability of the clot. In the lower half of the image, you can see residual flow grade 0, residual flow grade 1, then flow grade 2. So in residual flow grade 0, as in our first patient, there is no flow across the clot. So you will not visualize anything beyond it. Whereas in residual flow grade 1, you can just see a faint opacity beyond the clot, whereas in residual flow grade 2, you can see a nice line connecting the 2 flows. So these are how we will angiographically determine the permeability or the porosity of the clot. Then there have been these 8 studies which were meta-analyzed, and they said that if the clot is more than 8 or maximum 16 mm, then it is unlikely to open up with the IV thrombolysis. But our patient had something around 28, 29, which also opened up, and 12 millimeter also opened up. Then in imaging, we should take MIP images to see for the clot length. But length does not always equal to equivalence, because a length of 1 centimeter in M1, which is a bigger lumen, is not equal to the 1 centimeter in M2, which is a smaller lumen. The area will differ. So length is not the only thing we have to look at. Then obviously we have discussed the thrombus density. You'll place your cursor on the thrombus and see what is the Hounsfield unit. So we analyzed our patients, and I made this table to show what was the why did these patients have such a good response to thrombolysis. So first of all, our door to needle time was as minimum as possible. So 15 minute, 22 minute, and 20 minutes for the 3 patients respectively. So our average is around 28 minutes in the last few quarters. At least 6 quarters we have averaged under 30 in the last 6 consecutive quarters. So we need to have a stroke code protocol, and we need to have a team which is ready to do stroke care within 5 minutes of the patient arrival. We just have to do the initial assessment, GCS and IHS, and pulse rate, BP, and sugar, and we immediately go ahead with imaging and ruling out the contraindications. Then onset to needle time, as you can see, the patients also came relatively early, other than the patient 2, which came after 2 hours, but still in window. So that was another good thing from the patient. They arrived in the golden hour. Then an IHS change. So there were dramatic improvements as shown. CT aspects were relatively good. Clot length in the first patient, there was complete occlusion. Second and third were actually big clots. They were 12.9 and 29 millimeters respectively. But the porosity was not there in the first patient, but second and third patient showed some flow beyond the clot. So that was a good prognostic marker for them. Clot density was around 70 to 65 and 92 Hounsfield units. So they say above 70 to 80, it is difficult to open up, but it still opened up in the last patient. And clot burden score was high in the first patient. It was completely occluded, and the other also was in proximal MCA. So maybe the collateral status also was a factor, because they had, all 3 of them had very, very good collaterals. The collaterals were almost as good as on the normal side, distal flow. So that was why they were still well preserved, and immediately after opening of the vessel, they became normal. So these are the 3 articles of reference for this. So in European Journal of Neurology, impact of IV thrombolysis on recanalization rates. So they have given a number of 12%. Some studies say up to 20%. But in our last 2 months, last 5 LVOs, 4 have opened up. 1 showed clinical improvement, but his basilar occlusion worsened. So probably in anterior circulation, it is more easier to determine. And prediction of early recanalization, again, they have seen all these factors, clot length and all. But this new article in Neurology, which was just published 1.5 months ago, that if you do not do pre-treatment thrombolysis, and if there is a low aspect, both are associated with recanalization, even if you take for mechanical thrombectomy. So the bridging is why it is recommended to do the bridging thrombolysis and then take for mechanical thrombectomy. Then this was the Tetris study, which showed 20% with tenecteplase, and they have done similar study with alteplase, which is predict recanal. That was both were compared, and they said that if it is a more than 10 mm thrombus, then we should see possibility of tenecteplase being more effective. So that might be preferred. Then why do we need to give thrombolysis before thrombectomy? If we have a center in which both are there, why? Or even if we are referring the patient to a center, first is that many get recanalized. All our 3 patients got recanalized before we needed to do thrombectomy. Then say like Ramya madam is there, she is doing thrombolysis, and then she's referring to a center which is maybe an hour away with thrombectomy or 2 hours away, but she has already taken an action, and maybe by the time patient reaches the center where the MT is to be done, already it has opened up, or she has taken some action and given patient a better chance while the patient is being shifted, or the fibrin breakdown might make the procedure itself easier. So these are the 2 upcoming trials in Japan, where they are doing head-to-head study for recanalization in LVOs, and then in medium vessel also they are seeing for recanalization with tenecteplase. Thank you, sir. That is the 3 cases.
Uh, so it was a very nice presentation of all these three cases, Dr. Siddharth. Uh, uh, there is already established that that LT plays in large vessel little bit more age as compared to tenecteplase plays. So all these three cases prove it not exactly right, and very good result of large vessel occlusion where a thrombectomy needed. The I think it more because of that your center door to needle time is very less. This is a very important thing that it's 20 minutes, 30 minutes you people are doing. So this is the I think most important reason of getting good results rather fortunate patient, and despite all the literature say about that, not a good result in all these things.
Yes,
Yes.
sir. I would want to say, sir, that I think it's a very you cannot do it alone. No one can do this door to needle or the stroke acute stroke care alone. I think it's all about the team, because 24/7, all 7 days a week, we need to have someone ready within minutes to respond to a stroke call. And there are tough cases, there are exceptions which we are really stuck. So I think everyone being on the ball, and even the casualty people have now started picking up strokes very fast, informing us, because we won't be able to come till they inform us. So
Yeah.
I think starting from the casualty medical officers to the radiologist, everyone is involved, and cath lab is ready at all times, and thrombolysis, the whole uh, system is ready to thrombolize within
Yes,
minutes. So I think it's that the whole team is being
definitely.
trained and being utilized.
Definitely. It's a teamwork. Without team, it is not possible to have such a very less door to needle time, as you are saying that 20, 30 minutes. It's quite good.
Siddharth, I personally feel that if there is one factor which has determined your good outcomes, it has been collaterals. Because these leptomeningeal collaterals, they predict the ability of the brain to sustain viability in the face of large vessel occlusion. So I think you've had good collaterals. That I think is the key. Because, large vessel disease, although it accounts for maybe about 25% of all strokes, they account for about 90% of the bad outcomes. So if you've had good results, it is simply because of good collaterals. That I think is the bottom line.
Yes, sir. I think all the three, as I've shown in the images, had very excellent collateral. So we do this collateral scoring, which is similar to aspects. So wherever we calculate the aspect, we calculate the collateral aspect.
Yeah.
So all of these patients had 9 or 10 collateral aspects. So that probably is the reason that why they sustained and why they didn't have penumbra.
Yeah.
Core. I mean, the core wasn't that big. Even though penumbra was quite big, the core still hadn't developed by the time we got to treat them. So I think that was a big factor.
But the point is, can you leave these patients alone? I don't know. Really, I don't know.
No, we haven't left them alone. Even after giving IV tenecteplase, we never left them. Even though they had clinically improved, we did a MR angio, and two of them, we took them to the cath lab also, because the recanalization we felt was not very good. But in the cath lab, by the time they went to the cath lab, in the 10 minutes, 15 minutes, again they had opened. And what you said about collaterals, because of the collaterals, the aspect score was low. Because otherwise aspects, not low, it was high.
Right.
So the collaterals do help. But I think, as Dr. Choksi said, and I am a very firm believer in this, that decreasing your door to needle time also is the key to good outcomes. So all of us, as neurologists, I mean, I've been trying to give this message again and again to many people that, reduce your door to needle times. And unless you reduce your door to needle times, you will not get good outcomes. Then you'll be unhappy. Then you will say that the drug is not working. But it is because you didn't work properly. The drug is there. The drug is known to open up. But you have to use it also properly.
Yes.
So if you use it, and how can you use it? Unless you have a dedicated stroke team, you cannot reduce your door to needle time. Now, the hospital will say that, no, you don't have so many patients, so how can we afford a stroke team? But unless you have the stroke team, how will you get more patients? And how will you get good results? And because good results beget more good results, and they beget more patients, so somewhere you have to break the ice, and you have to impress on the administrators that, stroke is as important as myocardial infarction. In fact, it is commoner, or it may be commoner in many parts of the world. And we have to develop this stroke team, a dedicated stroke team and a stroke code. And unless we do that, we won't get good results. And unless we get good results, more patients will not come. So it's a chicken and egg situation, but somewhere you have to break the ice. And I think, and I've had a lot of difficulty in convincing the administrators, but finally, they've all come on board, and you have to just persist with the administration, because they have their problems also. They have to see the bottom line. They have to see so many things. So you need to use your influence and your convincing power and show them statistics, which are there all over the world. And we have problems with mechanical thrombectomy. The cost is high. The availability of people is also not so good now. Of course, we've got very good teams, but for a long time we struggled with producing a good team. And but we have to do it. Unless we do it this way, I don't think we can ever improve. So you have to, convince your administration that this is the way to go. Yes, it costs money. Initially, it costs money. It costs a lot of effort, but you have to do it sometime in order to help so many patients. And even as I told you, IV thrombolysis is very cost effective. Even in our country, it costs, MT costs 5 lakhs, 6 lakhs. And sometimes the patient doesn't improve. He goes to ICU and you have to do decompressive cranectomy. Then it costs 10 lakhs and he's on ICU, ventilator, this, that. Family goes into poverty. Many people go into poverty. So, if we can use IV thrombolysis, and I'm a firm believer that you should use it first, because you save so much money and so much resources in a resource poor country like ours. So, everyone doesn't have tons of money to throw. Most of our patients are struggling for money. So I think it's an important message that we wanted to give. And if you can get the right patient, like what Siddharth has said, this type of come early, clot porosity, clot length. If you can study this and stratify it, maybe you can use it in a better way for benefit of many, many more people. So that was the message that really Siddharth wanted to give. Siddharth, did you want to give any other message? What was the message you wanted to give?
I think, sir, like I said, that neurology article, that there are now some trials being done on state to angio suite. But as it shows in India, because we save these patients 2-3 lakh rupees probably, or maybe more, based on their mechanical thrombectomy requirements, and then further ICU care, they were all discharged in 3-4 days. So I think thrombolysis is a wonderful tool, especially if used this early, and they opened up large vessel occlusions, which, as the penumbra showed, that they might have been left with morbidity or required a mechanical thrombectomy, which would be expensive. So I think even in the future, always bridging thrombolysis is going to be the way to go. And we need to give the patient that opportunity to open up with the IV thrombolysis before we...
But after saying this, we are not against, we don't want to create the impression that we are against mechanical thrombectomy. For God's sake, we are not against mechanical thrombectomy. We are looking at more cost-effective methods to help many more people. Of course, mechanical thrombectomy is good. In the appropriate patient, of course, you have to use it. There's just no doubt. So, many people get the impression that we are against mechanical. We are not against mechanical thrombectomy. But by doing this method, I think we can help many more people in a more cost-effective way.
And like sir said, I think sir had asked, what if we just leave these patients alone who have such good collaterals and, they have might improve. But I think as a perfusion study showed that the penumbra or at tissue at risk is so big, and we've suffered when we have seen patients who have improved, but their vessel hasn't opened up. many of them had then subsequently worsened, because that collateral is like the UPS inverter, which is just taking care for a while. If you don't
After that, it will
open up,
fail.
it will fail.
It will. Collaterals are a temporary bridge, but they're not as good. It's like the main highway is blocked, but the small roads are managing the traffic, but it can't manage the full traffic. Finally, it will fail. So it's giving you time, it's giving you this thing. So use that time diligently and try to make use of those good collaterals. Dr. Choksi?
Yeah, sir. Later on I really discuss with you the tricks how to convince the management regarding to develop a stroke unit in a center. I'm also struggling nowadays.
Yeah.
This
It's
is
a
the beginning
struggle.
of this
But
hospital.
finally, you don't let your foot off the accelerator.
Yes.
Finally, they will come round. It takes time for them also, They have to answer for money, they have to answer for facilities. They have problems also, not that we only have problems.
Yes, sir.
But if you keep your foot on the accelerator, I think they come round.
Yes.
Do you have a dedicated stroke cath lab, or is it
No.
sharing
We
with
are sharing with the cardiologist.
That's the difficult part.
We don't have so much volume. I mean, we can't afford. Cardiologists are doing, if they do 20, we do 1. So, so we are at their mercy.
That's the
We are
whole point.
literally at their mercy. But, someday in the future, if our numbers go up to that level, then maybe we can ask for a dedicated cath lab.
And
But
I
as
think
of
the
today, no,
cardiologist,
we don't
I
have.
think that the cardiologists have cooperated that if they have a planned procedure, then they usually take the patient out,
Take it out.
even if it's on table. So unless it's a PAMI, then it's a tricky situation. Otherwise, they generally, for planned procedures, they'll take the patient out and we'll be able to do that.
Yeah, you have to keep the cardiologist in good humor
Good
also.
humor, yeah.
So you have to be a politician, to manage all these things. So you have to learn politics also. You have to learn neurology, you have to learn stroke, you have to learn politics, you have to learn so many things in order to be successful. Yeah. I think we've discussed enough.
Yeah.
Dr. Ajinkya?
Yes, sir. As usual, sir, it was a very wonderful workshop and it has been appreciated in the comment section. The online view count for today is 275. It is little less than the last time, but I'm sure they must have been benefited and learned
But
so many things.
275 is a good number.
Good number.
Yes. But last time, sir, it was 370.
Last time was a blip, man.
Yeah.
275 people, if they are able to listen, I think it's very good.
It's very good, sir. Yeah. I'm sure they must have learned so many things about the thrombolysis. And as rightly said by you, sir, nowadays age is not a contraindication for thrombolysis. There are multiple studies which are coming out for a successful thrombolysis with tenecteplase in high age patients. And recently at ESOC Germany, there were posters of the ACT trial subgroup analysis, which have shown the safety and efficacy of tenecteplase in high age patients of the AIS. So, sir, I would like to thank Dr. Ramya ma'am and Dr. Siddharth sir for presenting those interesting cases, and many congratulations to them. And I would like to thank Dr. Ichapuria sir as well, Dr. Gilwat sir, Dr. Choksi sir for your expert comments and great practical insights. And we really want to work under your guidance for many such future programs, sir. And with this note, we can close this session, sir. And thank you so much, sir.
Yeah. Thank you very much.
Okay,
Yeah.
thank you,
very much.
everyone.
Bye bye. Good night.
Night.